Okay, you're ready for the second day of the SPAN conference. Good morning, everybody. My name is Gerard van Noordmessen. Most of you know me already. I'm a GIST patient myself and active in advocacy for many years. And I'm chairing this session together with Angelica. Maybe you can introduce yourself briefly.
I'm Angelica Sandakli. Yeah. I'm mother of a patient diagnosed in 2010, who is fine now. I'm coming from Infosarcome in France, and I'm with Spain for almost 15 years now. That's all.
Okay. This session is on surgery. Surgery obviously is one of the very important parts of treatment of sarcomas. We have two speakers. The first speaker is Sylvia Bonvalot, and she is very well known among the sarcoma community. She is specialized in sarcomas, and I've heard her speak and present many times at many conferences. I think you also have spoken before at one of the SPAN conferences. I don't recall exactly which one, but that's several years ago. And Sylvia is also working at the Marie Curie Hospital, specialized in sarcomas. And we are very interested to hear your presentation.
Thank you very much, and I thank the staff for the invitation. It's always pleasant to discuss with our patients. So I have to talk about challenge and pitfalls when operating on a sarcoma. So I think that the main important thing is to think before operating the patient and not after. And most of the mistakes we see are because the surgeon operates without any diagnosis, without imaging. And you must know that a successful surgery implies a meticulous preoperative management, which is an integral part of the surgical process. Surgery, it is not only to remove the mass, it is to think before to the strategy and how you will operate the patient. Does the patient need a neoadjuvant treatment? Is the imaging complete? It's something which is fundamental. So the first step, of course, is to perform the right imaging. And we see many patients who have been operated without any imaging, without, of course, knowing it's a sarcoma. And when you have to reoperate the patient to perform a large surgery, if you have no imaging at the beginning, it's very difficult to know what you will resect correctly. And so it's fundamental to have a good imaging at the beginning, to suspect a sarcoma, to discuss about the biopsy, and to have a clear extent of the tumor. Most of the time, we perform a MRI for extremity and then neck, wall, abdominal wall, thoracic wall, and pelvis, and it starts by a CT scan for abdominal tumor. For instance, here you have a GIST. You can suspect it is a GIST, but it is, of course, necessary to have a biopsy. And here it is a retroperitoneal sarcoma, which is in the back of the abdomen. It may be surprising for you, but especially for retroperitoneal tumor, we see many patients who have had an incomplete surgery because the surgeon and the radiologist underestimate all the tumor. I will explain. In fact, here you have a big retroperitoneal sarcoma, and you have a dedifferentiated part which is here, and it is obvious, even if you are not a radiologist, you see it. And you have the well-differentiated part, which is around the dedifferentiated part. Why it is well-differentiated? It's because it looks like the fat we all have under the skin. So it is a well... And the radiologist and the surgeon describe the dedifferentiated part, and they remove this part, and they left behind the well-differentiated part. So when you see the patient afterwards, the surgery is incomplete. So here it is a little bit caricatural, but very often the tumor is in front of the kidney is here, the well-differentiated part is here, and the surgeon remove the dedifferentiated part and left behind the well-differentiated part. So in fact, it is very, very important to have a good analysis of the imaging before the surgery with someone, with a radiologist or a surgeon who knows about liposarcoma, because one of the main mistakes we can see in our sarcoma center, it is this mistake. It is the first mistake we see. It is that a large part of the well-differentiated liposarcoma is left in the abdomen. When I see the residual mass, I can tell what is the specialization of the surgeon. If the part which is left behind is behind the kidney, I know it was a visceral surgeon. And if it is in front of the kidney, I know it was a urologist. So it's something which is very important, and it is one of the main causes of mistake we see today. And sometimes it's not very easy. For instance, here, the radiologist describes a dedifferentiated mass, 12 centimeters, and the surgeon was about to operate, and the patient was seen at our multidisciplinary tumor board, and we told, yes, but there is something well differentiated which is in front of the vena cava with some calcification. It is part of the tumor. So sometimes it's not easy to recognize this well-differentiated part, and if you do not pay attention of this imaging, you can just remove this part and the surgery will be incomplete. And one of the problems when the surgery is incomplete, it is that it means that the tumor has been opened, which is something which should be avoided, to open the tumor. And then, finally, when you see the patient, it is a big tumor most of the time, but you do not have clearly the diagnosis. Is it a sarcoma or not? Is it a GIST? Why it is important? Because you may discuss a neoadjuvant treatment, and the extent of the surgery is not the same when it is a benign tumor or a sarcoma. And according to the type of sarcoma, the surgery may be with more extension if it is like an epithelioid sarcoma, or more limited, for instance, if it is a well-differentiated liposarcoma. And of course, this, as it was said probably yesterday by Eva Walderman, it is an histology which is difficult, so it must be reviewed by a pathologist who is trained for sarcoma. Very often he will need immunohistochemistry, sometimes molecular analysis, and it is very important not to decide an extensive surgery based on frozen section. I had recently an example, a very bad example, of a young female who was operated for a mass on the uterus, and they did a frozen section. The pathologist said it's probably a leiomyosarcoma. She had an hysterectomy, no children, and the definitive diagnosis was a leiomyoma. So I always tell to our residents, do not take the decision for a large surgery without a good diagnosis made before the surgery. It is something fundamental, and again, we see a lot of mistakes which are due to the fact that the surgeon do not know what he is operating. He asks for frozen section. Of course, a good pathologist should refuse to do that. For the retroperitoneal tumor, which are frequent in my own activity, it's possible to do the biopsy by a retroperitoneal route to avoid any contamination of the intraperitoneal space. Usually, we prefer not to perform a surgical biopsy because in case of surgical biopsy, when it is an high-grade tumor, you may have an infiltration of the skin because the tumor will go out of the compartment she is at the beginning, and because of that, the surgery will be much more difficult because you have to resect the tumor which is here and to cover the vessels and put a free flap. So very clearly, the surgical biopsy, in case of soft tissue sarcoma, it may be different for bone sarcoma, but for soft tissue sarcoma, for instance, we are doing in Curie, but before I was in Gustave Roussy for now more than 20 years, I have no patient we were obliged to do a surgical biopsy. In all the cases, sometimes it's not enough for the pathologist. We redo a percutaneous biopsy with more specimen, but usually we always have the diagnosis with the percutaneous biopsy. And this is a clear advantage to avoid all these complications, hematoma, ectopic scar. Sometimes a non-specialized surgeon will do a surgical biopsy, but the scar is not on the route of the surgery after to remove the tumor, so it is a big mistake. So in fact, it's very important to have a percutaneous biopsy. And in fact, why it is so important when you plan your surgery? It is because merely excising a sarcoma is not sufficient, because you don't have a pseudocapsule, you don't have a capsule, and here you have a front of tumor cells, and you may have small cells which are a part of the main tumor, and if you just resect close to the tumor, it is enough for a benign tumor, but it is not enough for a sarcoma. For a sarcoma, you are supposed to have a rim of normal tissue around, so it will depend of the muscle you are or the group of muscle you are. Sometimes the tumor is not in a compartment, it's a little bit more difficult, but the principle is the same from the head to the foot. It is to have a margin of normal tissue, aponeurosis, muscle, around the tumor. And the pathologist will inform you on the minimal margin, because this is this minimal margin which will give you information about the risk of local recurrence. So usually, for instance, the pathologist will say your minimum margin is 3 millimeters of muscle. And you have the information, 3 millimeters of muscle is enough usually. So it is to have this information from the pathologist. Of course, you will fix the specimen you have resect and give orientation. If you just give the specimen like this to the pathologist can give you the right information. So you have a work at the end of the surgery to fix the specimen on a plate. Personally, I do a schema, and orientation of the specimen, and doing that, the pathologist is able to give you the margin. Where is the minimal margin? It's important because it may impact the dose of radiotherapy if the radiotherapy is delivered postoperatively. And again, from a microscopic point of view, why? That's what I told you. Even if the tumor looks clearly round, in fact, on the specimen, it's not so round. And on the microscopic view, you can see that the tumor is involving the muscle. And if you just resect the tumor along the main circumference, you will let in the muscle this. And that's a cause, of course, of local recurrence. So here the pathologists say the smallest margin was 6 millimeter muscle. So it's largely enough. But it is because of this, and maybe some cells in the tissue there, that you are obliged to do what we call a large surgery with clear margin. And it is exactly the same pathway for retroperitoneal tumor. Here, when you see the patient in your outpatient clinic, you don't have a retroperitoneal sarcoma, you have a retroperitoneal tumor. Where is the sarcoma? And with the imaging, you cannot tell where is the sarcoma. You see a retroperitoneal tumor. So first, serum tumor markers. Sometimes it may help to make the diagnosis, but most of the time you are obliged to do a percutaneous biopsy. And it is very important because for this retroperitoneal tumor, the surgery is absolutely not the same. For instance, for a germ cell tumor, most of the time the treatment will start with chemotherapy, and when you operate the patient, it is just the resection of the mass. You will spare all the organs which are close to the tumor. Here, lymphoma, you do not operate the patient at all. It is a pure medical treatment. Neuroendocrine tumor, and this one was benign, it is just resection of the tumor alone, no resection of kidney or colon or things like that. Desmoid, you will discuss at the beginning an active surveillance, and sometimes the tumor will decrease spontaneously. This benign sarcoma, you will resect only the tumor and you will spare the femoral nerve, which is obviously probably inside, so you will spare the nerve. And here is the sarcoma, and in this one you will perform a compartmental surgery if it is a dedifferentiated liposarcoma. So if you don't have the biopsy before, it is not surprising that the surgery is not adequate. So, of course, you will ask for a good staging because the indication of the surgery may be different if there is metastasis. If there is metastasis, of course, in the multidisciplinary tumor board, you will discuss between neoadjuvant chemotherapy. Sometimes you may discuss to resect the metastasis and to operate the primary. It will depend of the grade, it will depend of the patient, it will depend of many parameters. And of course, in such situation, it is absolutely necessary to have the multidisciplinary tumor board to discuss the best strategy. Because the best strategy is not always surgery at first. And if you operate directly the patient, you can miss some important part of the treatment. For instance, here in this retroperitoneal tumor, it was an Ewing-like tumor, and the patient received a neoadjuvant chemotherapy. I will not discuss of the chemotherapy because I see very well-known medical oncologists in the room, so I will not discuss the type of chemotherapy, but you see that between this and this, even if you are not a surgeon, it is easier to operate this. You will accept this. The tumor is much more smaller, it is not like this. And for the patient, what does that mean? That means that the surgery will be more conservative. So you have less things to resect. So it is, of course, very important to have this discussion before the surgery. Another example. Here, it was a colleague who was professor of surgery in Paris, and he has this big retroperitoneal mass, and the diagnosis on the biopsy was a desmoid. So according to our guidelines, I place the patient under active surveillance, and spontaneously, the tumor decreases, and you see the remnant tumor is here. You do not need to be a surgeon to understand that the surgery is absolutely not the same, and anyway, here the patient is totally asymptomatic, and of course we will not operate this patient. So it's very important. In this case, it was a second recurrence of a malignant nerve sheath tumor in a pre-radiated field. And in this situation, it is a good indication of isolated limb perfusion, which is a technique where you inject very high dose of chemotherapy in the limb to have a good pathological response and to allow a conservative management. And here it was a myxoid liposarcoma, which is very sensitive to radiotherapy. And the patient received preoperative radiotherapy, and you see that between this and this, it's much more easier, and the surgery is much more conservative for the patient. So the benefit is clearly for the patient. But you can understand that all the preoperative part, and as I said, this preoperative part is part of the surgery. Surgery, it is not only to operate the patient, it is all what is before and after, because you have to follow the patient. So all this preoperative part is absolutely fundamental. And then you operate the patient. So the surgery is the standard treatment of all the patients who have a localized soft tissue sarcoma. And as I said before, to perform a large surgery, it's suppose you have the diagnosis. It's suppose you have the diagnosis. Because if you don't have the diagnosis, there is absolutely no reason to perform a large surgery. It means that you need a rim of normal tissue around the tumor, which means that, in fact, you try during the operation not to see the tumor, because if you see the tumor, it means that you are too close and that you don't have a margin. And of course, as I said before, the specimen must be oriented for the pathologist, because if you do not orient the specimen, the pathologist cannot give you margins. So this is an example. The tumor is here. It is a white mass. And here you see when we operate such a tumor, we start the liberation of the noble structure, the vessels, the nerves, and we resect the tumor with a rim of muscle. And here on the specimen, you can see that we do not see the tumor. The tumor is inside. So it means that we have free margin. And here it is afterwards, we put a flap because the vessels were exposed, and we put a flap not to have no problem of cicatrization. Of course, sometimes we adapt the margins according to the subtype of the tumor. For instance, for a well-differentiated liposarcoma, which is called atypic lipomatous tumor, we perform a less extensive surgery, but conversely, for epithelioid sarcoma or for myxofibrosarcoma, we will perform larger surgery because we know that we may have some microscopic cells far off the tumor. But there is no standard about the quantity of margin to resect, and finally it is the experience of the surgeon which is important. Sometimes you have to adjust your surgery to the location and the histology. For instance, here you see that the tumor is very close to the bone, close to the skin, and you cannot have large surgery except if you perform an amputation. And you know that there is no better survival with an amputation. So if you can perform limb salvage, it is always a better solution. So here it was a myxoid liposarcoma, which is very sensitive to radiotherapy. The patient had neoadjuvant radiotherapy, and we resect the tumor with the periost of the bone, which is the margin of the resection. It is something, a tissue which is very strong, and it is enough. And we cover with a flap, and you have the final result. So here, of course, you cannot take a large margin because of the location of the tumor. So it's not always possible to have these large margins. And sometimes when you read the pathological report, you see, I have 0.5 millimeter margin. It's not enough. Yes, but sometimes the surgeon decides to spare a noble structure for you to have a better functional result. So example of repeat whoops following inadequate surgery. This is an example of a patient who had a very small tumor which was superficial. She was operated without any imaging. It was a leiomyosarcoma. With a piecemeal resection, the tumor was open. She had a re-resection by a non-specialized surgeon, without imaging, so he couldn't know how deep he was supposed to do. Again, it was marginal with a very quick revolution. And when I saw the patient the first time, it was this. You see all this big mass because the tumor was open, so you have plenty of mass involving the muscle. And here the surgery, of course, is much more complicated because if you resect the tumor with a clear margin, you will have a very big hole, a very big defect. So we were obliged to put a free flap, and the flap, the skin was not enough to cover the flap, so we had to add a cutaneous graft. And here the margin was 1 centimeter, 0.4. And I stopped following the patient because we are now more than 10 years. But very clearly, at the beginning, it is something which would have been very easy to resect after a percutaneous biopsy. And at the end, you have this, because the management was not correct. And in fact, it's very important to be operated in a sarcoma center after multidisciplinary tumor board. And here you have 2 studies which clearly show that when the patient is operated in a sarcoma center, the survival is better. And it is even more true for the retroperitoneal sarcoma because the local recurrence may impact the survival. So it's very, very, very important. So in many countries, some sarcoma centers are defined to provide this surgery with a specialized surgeon. So a part which is very, very important, it is the reconstruction. Because in fact, you are supposed to do large surgery, and because you have a large surgery, you have large defect and resection of some, for instance, colon or things like that, and you have to do the reconstruction, which render operable inoperable patient without the reconstruction. which allow you to perform surgery in irradiated field and for the quality of life. For instance, here you have a big sarcoma which involve the abdominal wall, and if you want to perform the resection with clear margin, it is a full wall resection. Here you have no more wall for the abdomen, so you are obliged to put a flap, and we put a free flap to cover the resection. Without the flap, you are not able to operate the patient. So it's very important to have a plastic surgeon in the team. This is the example of the second recurrence in a pre-irradiated field. To have a free margin, we resect the vessel and the skin, which was blocked because of the radiotherapy, and we put again a free flap to cover the resection. Again, here, if you don't have a flap to cover the resection, you are not able to resect this tumor. So we put two flaps to cover the defect. And here it is quality of life. The sarcoma is here. It was a rhabdomyosarcoma around the sphincter of the anus involving the vagina. So we had to resect the vagina. We put a flap to do another wall of vagina. Coloanal anastomosis. The colon was sewed on the skin, and an artificial sphincter. So all these reconstructions were done for the quality of life of the patient. We could have resected the tumor without any reconstruction, but all these reconstructions are important for the quality of life of the patient. Sometimes it's complex because you have association of reconstruction. For instance, here you have this big tumor, which is part in the abdomen, part in the thigh, involving the vessels. So we had to resect the vessels, and we put a vascular graft. We had to do the reconstruction of the inguinal ligament, which does the separation between abdomen and limb, and then obliged to cover the field. You cannot let the vessel under the skin, and this is the flap. So all these reconstruction must be discussed before the surgery. It's not during the surgery that you will discover that there is a vascular graft to put, a flap. It must be discussed with the surgical team because it involves a vascular surgeon, a plastic surgeon, and the sarcoma surgeon, me for instance. Quality of life, again, this patient, it was a young female patient. Originally, she was scheduled for an amputation. So, okay, it would have cured the patient, but amputation for a young female, it's really something major, and we discussed that it was feasible to have resection with clear margin and without too much functional impairment. So I resect the tumor, and the plastic surgeon put a free flap to cover the resection because a lot of skin was resected. So very clearly in such situation, the collaboration between surgeons allows to perform a more functional surgery for the patient. Another example, this is this huge tumor of the thigh here. You see, I don't have the MRI, but the tumor was involving adductor, and it was a very big tumor. You see that you have a large field after the resection of the tumor. If you do not have a plastic surgeon to put a flap, you cannot perform this surgery. You need to cover with a flap to be conservative and to have a functional result of your surgery. I think in many places this patient would have been amputated. So for the retroperitoneal sarcoma, it is the same concept. We perform compartmental surgery to remove the tumor in block with the maximum of free margin around the tumor, and it is especially true for liposarcoma. For leiomyosarcoma, we perform less extensive surgery, which means that we resect the tumor in block with what is inside, and here you see that the kidney is inside, and usually to have a free margin, we resect the aponeurosis of the muscle in the back, and very often the colon in front, which is, as you can see, it is here, it's laminated by the tumor. So if you keep the colon, you will have positive margin on a very large area. So that's the reason why we resect in one block with adjacent organ this tumor. We demonstrate with my colleague Alessandro Gonchi that doing a compartmental resection for this retroperitoneal sarcoma achieve better local control. So for instance, one of the first cases I show you, this is the retroperitoneal sarcoma, which was a dedifferentiated liposarcoma, and you can see that we have on the maximum area of the tumor, we have free margin because we have the mesocolon and the colon in the front, the peritoneum inside, the aponeurosis in the back, and finally, despite the fact it is a big tumor, we have clear margin on the maximum area of the tumor. But sometimes the tumor is very big and it may be a pitfall because, for instance, here the tumor is very big, encasing the kidney, and the main issue is to resect in one block without complication for the patient the tumor. It may be difficult, and sometimes we are obliged to have a very large scar to resect in one block this tumor. This is the post-operative view of the tumor. So the fact that this retroperitoneal tumor may be very, very big may be difficult to resect in one block. And finally, information. I think it is a very important part of the preoperative management of the patient because you have to explain to the patient first why you have to resect the mass, and sometimes something around the mass. For instance, I showed you before the colon or the kidney. You have to explain exactly why. Very often, I give to the patient a schema of the surgery and of the reconstruction for the patient to understand better what is the kind of surgery you propose. So this part of explication information is, in my opinion, it is part of the surgery, and it may be part of a legal requirement. I am doing a lot of expertise now, and some of the object of this expertise are non-information of the patient. So I think that first, it's important to give this information and to explain exactly what you are doing, why, the timing of your surgery, why, for instance, why you do not operate at first and you need a neoadjuvant treatment. It must be explained to the patient. So finally, the requirement for a good surgery for soft tissue sarcoma, first, to have an adapted imaging and a good analysis of this imaging, especially for the retroperitoneal sarcoma. Remember that half of the mistakes we see, it is an under-evaluation of the tumor. That's very, very common. A good staging according to the histological subtype, because if there is a metastasis, the treatment may be different. So it's very important to have this and to have the multidisciplinary tumor board before the surgery. The percutaneous biopsy, the review by a specialist pathologist, of course, the multidisciplinary tumor board to discuss the global strategy. The surgery should be done by a surgeon which is really trained for this type of surgery. globally, it is an en-bloc incision with a clear margin, which means to have a rim of normal tissue around the tumor, which means that you know you operate a sarcoma. And it is very important to anticipate all the reconstruction. Sometimes, if you have not reconstruction, you cannot do the resection, but sometimes it is for the quality of life of the patient, and it is very important. And of course, informed consent of the patient. Thank you.
Thank you very much, Sylvie, and for your extensive overview of surgery. And it's clear that you could speak for a longer time, I think, with all the examples that you know from your experience. Thank you very much. But in view of the time, I think we have to continue. So.
Thank you. We will now welcome Jendrik Hades, who comes from Germany, talking to us about clinical trials and surgery and the relevance of the patient's preference for the study design. So.
Yes, thank you very much for your kind invitation. It's a great honor to be here, and what should I say? What should I say after this talk? Yeah, perhaps a lot of things are said, and they are very, very important, the planning before surgery, but also, as you said, the patient participation before surgery is very, very important, because the success and failure in surgery are often not so far away. So we all know if we do big tumor surgeries, you have to have respect before these surgeries. You cannot say it's easy, I do it without a plan, and then everything will fail. So it's very, very important to know your own limitations as a surgeon, and you have to have, let me say, you need to be very, very careful in these surgeries. And we know, as Albert Einstein said, the truth is relative. We do not always know everything regarding the oncological result, what will happen in the next 10 years with this patient, because the biology of the tumor, everything can have an influence on the treatment of the patient. So we have to tell the patient what we know, where we are relatively sure, and what we do not know, and we do not know everything. I think this is very important, and therefore, in my opinion, patient participation is very important. I thought a long time, what can I say here in this presentation, patient participation? And first I looked to PubMed, and I thought, oh, it's easy. I make studies, I show studies, patient participation in sarcoma surgery or in sarcoma treatment. And if we are honest, we have not so many papers regarding patient participation. There is one, I think, out of the Netherlands I reviewed, but it's not published up to now. This deals with the topic, what is the physician perception of the informed consent of the patient and what feels the patient? Is this correlated perfectly, or is the patient has the patient another thinking of the informed consent than the physician has? And it was very interesting, but it's not published. Therefore, I cannot show. But I think I can encourage only to make more scientific research also about patient participation. So PubMed was relatively difficult, so I thought I can tell you a little bit about things I talk with the patient about tumor resection, about the influence of adjuvant, neoadjuvant local therapies, about definitive radiotherapy, because we in Essen have the Ewing Sarcoma Study Center, and I would say we treat 30 to 40 Ewing sarcoma patients per year, bone sarcoma patients, Ewing sarcoma patients in Essen, so I think we have some relevance here. And I want to talk a little bit about reconstruction techniques, not about flaps, what you have shown very good, about bony reconstruction techniques. And there are different possibilities. Let's start about tumor resection. This is an osteosarcoma, a tumor. I know it needs chemotherapy, but this is an osteosarcoma of the pelvis. And we know in osteosarcoma that the patient's chance to survive is surgery, chemotherapy and surgery. You have to remove this tumor. So here in patient decision making or informed consent, I have to tell the patient, if we can do the surgery, we have to do it. But of course, I have to tell the patient about mutilating surgery, about what can happen, impotence or something else, walking abilities, etc., etc. So I have to talk with the patient. But for me as a surgeon, and I think also for the patient, it's more easy because, you know, I have an osteosarcoma, it's metastasized or not metastasized. The only chance is surgery of all tumor masses I have. So this is, it should not sound, this is more easy to say I have to do surgery. Here, 28-year-old woman, a very big osteosarcoma, and you see here the extension to the midline. Here is a myelon, the spinal column, and you see here the tumor in the sacral level, and you see this. You see this has the same sign as this, and this was a tumor thrombus. This means this osteosarcoma, planning is everything before surgery, as we heard before, and we knew that this is a very critical situation, but the young lady had no lung metastasis, and we talked a lot. We talked a lot about the only possibility to survive if we try to make a hemipelvectomy, hemisacrectomy, and we cannot guarantee that we put out the tumor completely. And we said with the vessel surgeons, we try to put out this tumor thrombus. And we all know the prognosis with the tumor thrombus is even worse. But the only chance is to do it. We did it, and honestly, we have to say that the patient, the good news is she survived 2 or 3 years, then she died of disease, but the hospital stay was long because of wound healing disturbances and so on. And sometimes, or always, I ask these patients, do you regret? And did a mistake? And I think this is very important, self-reflection, and I do not regret it, but finally we failed in this case. This was the tumor thrombus we put out additionally. And we know that pelvic osteosarcomas have a poor prognosis. We know it, but you see here the survival curves. You have, of course, a chance of 50% to survive the disease 5 years after surgery. And we know that negative factors regarding survival are size of the tumor, metastasis, or if the tumor had already recurrence. We know it. But you have to talk with the patient, and the only chance is if you want survival to do the surgery, if the patient agrees. Chondrosarcoma. Chondrosarcoma, for your information, is the most common bone tumor in the world, and we have in Germany approximately, we say, 400 cases of chondrosarcoma per year. And fortunately, a lot of chondrosarcomas are well differentiated at chondrosarcoma grade 1, let me say, and high-grade chondrosarcomas are not so often. But we know that we have in high-grade chondrosarcoma the only chance of cure of the patient if we resect it. We have to do a complete resection of this tumor. In contrast to osteosarcoma or Ewing sarcoma, chondrosarcomas often appear in elderly patients, but you have the only chance to resect. And you see here survival of patients with unresectable high-grade chondrosarcomas. And you see, if you don't resect overall survival, you have no chance. So it seems to be easy. You have to tell the patient, you need the surgery, the bone resection, otherwise you cannot survive. For the surgeon, more easy. But we have also chondrosarcomas in the pelvis which are not so malignant as I told you. And this was a mistake. Of course, I do mistakes. I did informed consent with the patient. This was a 76-year-old patient with this mass. And this was an incidental finding. He got a CT of the pelvis because of a pulmonary embolism. Image-guided biopsy, chondrosarcoma grade 1. Well differentiated. And we said, oh, he was really ill, he had heart failures and so on, and he said, I'm 76 and I want to walk. And so we decided not to do surgery, and he got a heavy ion radiotherapy in Heidelberg, but it failed. It became bigger and bigger. Here you see, this is the tumor is getting bigger and bigger, and we then finally did with 78 the hemipelvectomy. This means to remove the acetabulum, a very big surgery for the patient. And yes, it was finally the wrong decision. Perhaps we should have done the surgery before with 76. I asked the patient and he said, I'm 78 now, I had 2 years, I did a lot of sports and so on, and it's okay for me. So we did the hemipelvectomy later on, but it was finally a wrong decision. Ewing sarcoma, in my opinion, Uta sitting here in the room, is for a tumor surgeon, for an orthopedic oncologic surgeon, the most difficult decision together with the patient, because we have first a very good prognosis of these patients, we have very good chemotherapy options, and we have two possibilities of local therapy. This is surgical resection, this is radiotherapy, and perhaps we have third, this is surgery and radiotherapy. And you have to discuss with the patient the pros and cons. And if you look for the pelvis again, you see here, this is the overall survival of the patients. And you could say, okay, in all pelvic Ewing sarcomas, surgery plus radiotherapy is the best. Here you see, surgery, radiotherapy. Easy. Surgery, radiotherapy, no problem. But what do you tell a patient, a 70-year-old boy with a Ewing sarcoma of the pubic bone, and you say if we have to resect it and he can get problems with impotence and so on, you have to discuss it with the patient. Or what do you tell a patient with an involvement of the spinal column, with neurological impairments? Do we have to do it because you have this positive effect? You have to discuss a lot. And this is, for me, patient participation means not one talk. Patient participation means sequential talks, 6 weeks before surgery, 4 weeks before surgery. You have to think about the decision. And Uta could show with all of the Ewing studies that we know in the pelvis that the size of the tumor volume matters. It can make an influence. You see that smaller Ewing sarcomas of the pelvis, the cutoff is 200 milliliters, have a better prognosis than bigger Ewing sarcomas. This is very, very important in decision making. And we know that in smaller Ewing sarcomas, this is only radiotherapy. Radiotherapy can be done only. This means only radiotherapy, no surgery. You have to discuss it with the patient. The problem is what we have. If you make not everything of therapy, you do not everything, there is one rule. Over-treatment, you could never prove. You could never prove if you did an over-treatment. Under-treatment will be a local recurrence. So this is for me, a very important message that you do not know always what you have to do, and retrospectively you cannot answer these questions of over or under treatment, or over treatment, sorry. In big tumors, in big pelvic Ewing sarcomas, you see here that surgery plus radiotherapy has an important improvement of prognosis. And for me, as a surgeon, it's easier to convince a patient with a big Ewing sarcoma to do surgery because I know this is a relevant advantage. Small Ewing sarcoma, you see here, a very small. She was a pilot, 28 years, pilot. She said, I want to be a pilot in the future too, and it was a small Ewing sarcoma. According to the data, we did only proton therapy, and it was successful. She could do her job, and we did not do hemipelvectomy in this case. Small tumor, Ewing. You see here in the dorsal part of the os ilium. This is an easy tumor, and we did a hemipelvectomy and reconstruction with these rods. Of course, you can say you make only radiation, it's a small tumor, but if we can do, we would favor on doing surgery also in small Ewing sarcomas. And it was perfect. The patient has no limping, no problem. But you have to tell the patient the alternative about definite radiation therapy. Very big Ewing here. And we have seen the pictures of neoadjuvant chemotherapy results in soft tissue sarcomas also. And in Ewing sarcoma, you see here, due to neoadjuvant chemotherapy, the tumor shrinkages very, very much. But we know that we have a better prognosis by doing hemipelvectomy. We did it. You see here a very big hemipelvectomy with reconstruction of the proximal femur too. And this was successful, and the patient had a relevant survival advantage and is without evidence of disease 15 years post-operative. 28-year-old woman. Ewing. Lung metastasis, tumor. Here's the tumor. Here's the midline, the myelon. We did radiation therapy because we said we make no mutilating surgeries, paraplegia of both legs. In these cases, we do definite radiation therapy if we have mutilating surgery. And we know in Ewing sarcoma of the sacrum that the prognosis of these patients is very good also if you make only radiation therapy. You have not to do big surgeries in these cases, and I'm very proud that Uta published recently last month this paper, Ewing sarcoma of the sacrum, all data of the Ewing sarcoma studies, of 2 Ewing sarcoma studies, and we could show that the survival of these patients of Ewing sarcoma of the sacrum, not so often, you see here we have 124 patients, is very good also if you make only radiation therapy, but in some cases surgery also can make an advantage, especially in where you can achieve a wide surgery. But we could show that Ewing sarcoma of the sacrum have a very good prognosis, and this is the first paper, in my opinion, Uta, where we discriminated between the level of the Ewing sarcoma. S1 means the big sacral level, and below means the sacral levels, which you can easily resect. And you can see that Ewing sarcomas, which are more distally in the sacrum, have a better prognosis than Ewing sarcomas, which are more above, because they are bigger and you cannot make surgery so easy. And of course, in Ewing sarcoma, you also have to think about primary metastasis at diagnosis. Of course, you have to discuss with the patient if they have metastasis that the prognosis may differ. You have to discuss a lot, you have to speak a lot. Reconstruction, 6-year-old boy, osteosarcoma here, osteosarcoma metastasis here. Who? Lung metastasis. Difficult. What to do? We decided to make a rotationplasty on this side, and we decided to do here a proximal femur replacement I will show you. You can ask us, why did you did surgery in this case? Osteosarcoma, the only chance is to remove all of the visible tumor. It's the only chance. Of course, if he would have so many pulmonary metastases that it makes no sense, we would stop it together with the oncologists, together with the parents in medical, in tumor conferences. Very, very important. You have to make these tumor conferences, so we do not do the decision for ourselves. This is a rotationplasty. This is a hip joint, and this is the tibia bone of the lower leg. So we put in we removed the complete femur tie, and did then put in the tibia in the acetabulum. And on this side, we put in, on the other side, where the metastasis is, we put in a tumor prosthesis for very small children, because we said on both sides, a rotationplasty, in my opinion, this was never done. And look here, the prosthesis dislocated. But this was patient participation. We know if we put in tumor prosthesis of the hip in very young children, it's in Birmingham published, in Essen now published, it's well known that there is a dislocation in all cases because the pelvis is not growing so far. So we know it. You have to tell the parents before that this surgery or this complication we cannot avoid until now. Perhaps we are getting more intelligent in the future. And then you see here we removed it and we put in here a socket and put it in. And I saw this boy last week. Of course, it's not perfect, but he is now surviving 3 years, and he has, in my opinion, a good quality of life at school now, so I think the decision was right. And this is rotationplasty. This means you remove the thigh, and the leg is rotated, and the ankle joint is then the knee joint. It's a very good surgical option. It's a very good surgical option, and you have the sciatic nerve, and you have feeling of the foot and everything. It's very good, especially in children, and we like the surgery in these cases. The other possibility is to put in expandable prostheses. You see here a prosthesis. Here you see this is a receiver. Energy goes through the skin, and then the motor. Here's a motor inside, and you see here this gap. This is a motor. Here is a gap like this, and here's a gap like this. 1 millimeter per day you can do, and it's very, very nice. A very non-invasive elongation process. But we have failures of the elongation process, and you have to put in, if you finish the elongation, a normal prosthesis for adults. This means if you do modern growing implants, you have to know you need service surgeries, so it's not only one. Last but not least, rotationplasty is one surgery. We have a low complication rate. We have a very good function. But cosmetics are of concern nowadays. We know it, stigmatism of the patients. In prosthetic group, we have higher complication rates. We need service surgeries. And the function is sometimes not so good, but you have the physical integrity of the patient. And this is today a very important topic. And you see here, secondary amputation after limb salvage. This was an 18-year-old boy we put in this prosthesis, and he got 20 revisions of the prosthesis. And then he said, Hades, I don't want it anymore. I want an amputation, and we did the following. We did an amputation. We preserved the stem. You see here, the stem is from the prosthesis, and we put in a special end piece with a special amputation, and this is the exoprosthesis. And this patient is very satisfied. And I asked him, do you regret? And he said, during my childhood, I had my leg. This was important. Now I want function. For me, it was the best decision. I do not regret, but I want a secondary amputation due to the big problems with the prosthesis. In conclusion, we need patient participation in tumor resection, in the decision of adjuvant, neoadjuvant local therapies, in the decision about definitive radiotherapy, especially in Ewing sarcoma, and we need patient participation in reconstruction techniques, especially in very young children. So you see, it's teamwork, not only between the disciplines of medical treatments, also with the patients. Thank you very much for your attention.
Thank you for your very engaging talk, which made it very clear that it's really a discussion between the surgeon and the patient, and each case is very individual. As we are already far behind our schedule, I don't know if we have time for 2 or 3 questions.
Hello, I'm Simona Ene from Romania. And my question is, if you tell to the patient about the possible disabilities as a result of surgery, I know it's very difficult to talk with patient before ahead surgery about this topic, but for the patient it's very important to assume the decision of surgery and to be somehow further prepared for a new normality.
In my opinion, you have to, this is a question of informed consent. You have to have, as Sylvie Bonvalo said, we need a good plan as a surgeon, and we know that you need sometimes plan A, B, C, D, and you have to talk with the patient, and you have to talk with the patient about possible mutilation. Of course, we do it before. It's, in my opinion, mandatory to talk with them.
Yes, I think that for very big surgery, when there is a clear functional impact, it's very important that the patient could meet another patient who had exactly the same operation. And for instance, in my outpatient clinic, I always have a patient who receives the same kind of surgery, and I ask, do you want to talk to my new patient? And very often for the new patient, it is important to have the same explication than the surgeon, but with patient words and patient experience. So I very often I do that because most of the patients are very happy to discuss with other patients, and I always ask to the patient, of course, do you agree to, but I had no patient who said no.
I can only underline this. Peer patients are very, very important because they can explain it better than we as physicians sometimes. Uta.
Yeah, and you also have some movies, right, from people. So if there's no peer patient available to just show how the function could be.
We have movies, and perhaps in the future with virtual reality, we can discuss about virtual reality that the patient can imagine easier. So I think there are technically new aspects in the future.
I think that movie is nice, but the contact with other patients, I think that the contact is something very important. That's,
And it's important that you discuss with the patient early. If you know that the surgery will be big and you have time because chemotherapy will start, then you have to stay in contact with the patient and with the peer patient. So you need the time that the patient who gets the surgery in 6 or 8 weeks has then the possibility to talk with others, yes.
in fact, in my talk, it was one slide at the end, but I think that the discussion with the patient to explain why I resect the kidney, for instance, why I do that. If I do not that, if I don't perform that, what is the results? And to have a good explanation of the roles of surgery of sarcoma, what are the roles, why I do that, and to explain what is the result for you in your day life. I think it's very important, and if the patient understands the surgery that you will do, the results is always better, in my experience, and that's very, very important, this explanation, discussion, and to understand why we do that, it's very important, especially when the surgery is a large surgery.
Thank you for the presentations, and I think this approach of having peer patients, that's really great. I think I would have loved to have a peer patient to talk before the surgery. I'm not sure how I would have reacted. Maybe you don't want to hear all the possible consequences, but I think it would have prepared me better. But my question is now where to find those peer patients, because as we have learned, there are so many different types of sarcoma and different operations. I personally have not yet met somebody who had the same en bloc resection than me. Yeah.
Normally we have reconstruction techniques do not differ so much. We have peer patients nearly for all cases, I would say.
Well, it's a pity that we don't have more time because it's a very important topic, I think. Let's thank both speakers with